This is Dying Your Way.
Welcome everyone to the Dying Your Way podcast. I'm Claire O'Berry and I'm your host. Returning to the podcast is Dr. Fred Mirarchi. He is an emergency room physician. He is the CEO of MIDEO LLC, and he is also he's the chairman of the National Palliative Care Committee for the USACS, which is US Acute Care Solutions. And we're going to find out more about MIDEO, and we're also going to find out more about just what his thoughts are, particularly pertaining to palliative care. But I'm very excited about talking about how AI is going to be affecting medicine in the next few years. And also, I'm concerned about issues going on with the healthcare system in the United States. So he'll help us put that into perspective. He's the nicest man and just really an expert to go to about a lot of these things. So without further ado, I am going to introduce you again to Dr. Fred Mirarchi. Hello,
Well,
Dr. Mirarchi.
hi. Well, thanks for having me, and thanks for having me back, actually.
Oh gosh, I love the time that we had. That was 2020. So we were in the middle of COVID. It was, and I was in the middle of getting my MIDEO card, which is hard to see in the light, but that's my MIDEO card. It's faded now because it's been on my refrigerator, but I have another one for my wallet. And it's got the QR code on it. And I can't tell you how many times I have demonstrated that to people here in Australia, well, wherever I go. And I always love to see their jaw drop when they see what a wonderful tool that is for advanced directives. Um, I think the first thing is just I'm curious, since we talked last, how has MIDEO evolved over the last 5 years? And probably by now you have some stories to tell about some real differences that the MIDEO card, so many
Well,
stories. Yeah, to tell the audience, it is such an effective tool. And I want you to hear it from the creator of MIDEO right here.
so there's a lot of different stories, both good and bad, and as far as what's happened over years. And what primarily has happened since we had last been together is I've come out of the UPMC health system. I'm no longer an administrator within that system. In 2022, I resigned as the MIDEO software platform and medical service line was acquired by US Acute Care Solutions, which is the largest physician-owned acute care practice in the nation in the United States. So it was a very, very transformative time, and we got to build the software out bigger, stronger, faster, make it more available. And now we have patients in 6 countries. We have patients in almost all 50 states that have
Wow.
utilized and so on. So, the process of it has become really, really good. We've gone to having it, just as an ID card to here within a month or so, we're going to have it on your phone as far as in widgets and so on. So a lot
Perfect.
has happened. A lot
Perfect.
is developed, a lot is moving. There's been a lot of transformative change within medical systems. A lot of medical systems now can bill for advanced care planning, but still tend to use their old broken down processes, which really isn't such a great thing, but at least they're starting to have the kind of conversations, and
So
before
when you
they would.
say they pay for it, you're talking about insurance or Medicare, Medicaid. I mean, it's it's a it's an advanced care planning appointment with your doctor that is basically free if you have insurance or you have Medicare or Medicaid, correct?
Yep. Outside of applicable copays, here in the United States, every plan typically will have a copay and so on. But
Yeah.
yeah, you now have coverage to have these kind of conversations. So again, they're not the best conversations that people are having, and they're using the older, broken, barbaric, paper-based kind of tools that we're in the 21st century and we're still using paper in medicine. It's ridiculous.
Yeah.
but at least they're having them. They're having some conversations. So it's a good and it's a bad.
So I want to just back up because I know that some people will want to go back and listen to our 2020 interview where, you really break it down. But MIDEO stands for My Informed Decision on Video. My
Correct. Yeah.
Okay. And I think the important part of that is informed decision. So we have an appointment with a doctor such as yourself, and we really go through an advanced directive and where we are in our own health journey and what is a likely trajectory that we have over the next 5 years, 10 years, 20 years, wherever we are in our life.
Yep. So what we
It,
do is typically we do a medical consult. We dig deep into your history and then we risk stratify you. Like you said, look at that trajectory. If you got a 1 year trajectory, our conversation is different and our planning's different. If you got a 20-year trajectory, it's completely different. One
mhm,
end of the spectrum, we're trying to make sure people don't over resuscitate you. Another end of the spectrum, we're trying to make sure people don't under resuscitate you.
right.
And those are two big problems that happen with standard advanced directives. Most people guess because they don't know you, right? If you go to an emergency room and see me, I'm a medical stranger to you, right? You
Hmm.
don't know me. Well, I know you, but the person in front of me typically won't know me. I won't know their values, their traditions, their beliefs, their religious beliefs, anything that may actually impact their care and treatment. But then I have to make snap decisions, right? Sometimes I have time, sometimes I don't have time. And it's the worst feeling in the world to actually make a decision for a patient that you then later find out is wrong. So
Yeah.
it's time to really jump in the 21st century and utilize video the way it can be utilized to make sure we keep patients safe.
It's the patient safety issue for you more than anything, right? I think I
Always been.
remembered you saying, you really don't have, it's not that you don't care, but that you don't care one way or the other. You just want to do what it is that they would like if they could talk for themselves.
Yep, absolutely. And again,
Yeah.
you said it best. I don't have an opinion. I don't. There's so much happening in medicine, and people have different beliefs and what's happening.
Hmm.
Who wants to look to VSED and who wants to look towards medical aid in dying? Who wants to extend treatment? It's not my decision. It's really your decision, but people want to take that decision away from you. And the best way that you can actually have a role in your decision is to be able to speak for yourself. And paper doesn't do it. It's a guess. I'm basically guessing off of a piece of paper what I think you want.
Yeah. I mean, what they're doing here, I mean, they don't, I mean, we have video, but I mean, it's not widely available right now. And so what they're doing is they upload the advanced care planning documents that you have into something called My Health Report.
Mhm.
And so if an emergency room doctor really did not know who you were or what you wanted or anything, they would know to go to that computer program that is linked all across Australia and just hope that your paperwork is going to be in there. But again, it's long. It takes a long time to interpret it. And that MIDEO card's just like psh, 2 minutes.
Yep.
Just need 2 minutes and you got it. Yeah.
And we remove the guesswork. The guesswork literally, so in that My Health report, you get some physician in Australia who's going to look in there. And again, they're going to get a paper-based document that's an interpretable document.
Mhm.
And you got to hope that they interpret it correctly. Whereas with video, 5 seconds, that video is pulling up. In 5 seconds, your documents are pulling up, and structured in a way where we make it so that there's a stepwise process that they have to go through to not just reflectively make a wrong choice.
I think there are the same as there would be in the United States from an emergency room's doctor point of view, a real fear of litigation. And so, because of that, they are going to tend to over medicalize the situation if there's any guesswork at all, you know?
Not so much anymore. Not so much. The major push here in the United States, even abroad, is really to, and I can remember the day I was asked this question by, I guess someone more advanced in palliative medicine who I guess should have had in his mind more more say into what was actually happening with people. But he looked at me and said, "Hey, what gives you permission to treat somebody?" And I said, "What do you mean?" He goes, "Well, if somebody's unresponsive, what gives you permission to treat somebody?" And I just reflexively said back to him, "You did. You're older than me in this space. You all set the standards. The standards are the standards of care. If
Mm.
someone doesn't have wishes documented, the assumption is you save that life and then figure out what's needed." So that push is changing dramatically in the United States. And that push is changing because of payer systems, right? Everybody's looking to figure out how to curtail the $400 billion or so that's spent in end of life care, right? It only accounts for about 8% of the US spending and so on, but that 8% is still some $400 billion. So payers and Medicare are looking for ways to curtail that.
Is that good or bad in your opinion?
I mean, the issue to address is a very good issue. The way they're going about it is suspect in my opinion. Just
Yeah.
because we want people to have these paper-based documents, and we have people, talking about now trying to enforce them and holding physicians accountable to them. But the primary issue is still broken. These are such vague documents, and a person is so clinically complex and variable. There's a time frame as to when you follow that document, when it's appropriate to follow that document or medical order. And that's the problematic piece that we have to figure out how to do better. We have to figure that part out better. We know we can do it with video and MIDEO. But if you expect it to be done with just paper-based documents alone and the level of training that's out there for medical people to understand them, it's going to be a pretty ugly time frame. And it's already starting to develop. We're
Did
already
I
getting. Go ahead.
did I hear you say that there was now some new law or something that if a doctor doesn't interpret the document correctly, that there's litigious action that can be taken on the doctor or the facility?
Oh, absolutely. So it's not so much the law. The law has always been if you have a legal document, it's supposed to be followed, right?
Right, right.
The issue is now coming up in what we call wrongful prolongation of life. And now doctors are being sued because they saved a life, right? And it's because somebody
Who
didn't
who
really,
who is suing them?
usually the families.
Oh, okay.
Yeah, usually
Okay.
the surviving families. And there's multiple reasons for that are happening, but physicians are being sued today for saving a life, which is never been heard of, right? Up until the past 5 years or so that this is starting to
Mm,
occur. And it's
mm.
starting to occur more rapidly. And now you have advocates out there, and some of my friends are in this space as well, and they're advocating that physicians be held accountable to follow the documents. Well, so if the documents are broken, and I'm not sure they should be followed at that point in time, but now I get sued, what's going to happen? It's going to force doctors to make bad decisions for patients. And again, we need better tools if we want to hold physicians accountable and say patients are safe to go through a very complex healthcare system with those kind of documents.
I remember in the TRIAD studies that you were the author of, the research that you did, that there were some shocking statistics that I remember about if an emergency a person comes to your home, and it may be different now, but I remembered it was like there was a 90% chance they were going to interpret it. If you were seen by a nurse, there was like an 80% chance that it was going to be misinterpreted. And if it was a doctor, there was a 70% chance that it was going to be misinterpreted. I mean, have those statistics changed since then?
No, nope, not at all. And we've shown it time and time and again. And it's funny because the initial triad studies were deemed suspect by a number of people in this space, right? But the reality of it is, years later, more definitive studies looking at multiple centers and so on and
Hmm.
treatment decisions are showing the same levels of discordant medical care to that same actual percentage or worse. So at this point in time, again, you really don't have a person outside of me and some people I work with advocating for the changes that are needed. But we have a broken system that's propagated across the United States. And then we have a broken system that is now going to be, tried to put some regulations around it or some enforceability around it. The doctors, right? Holding the doctors accountable to whether a patient lives or dies because of a document. That's broken. A piece of paper shouldn't tell a doctor, if you live or die. You should be able to tell the doctor if you want to live or die.
Mm, yeah. Um, I guess I was hoping for improvements in that. But tell me about some stories about when it made a positive difference for clients that you've had, patients that you've had because of it.
Yeah, so I've literally had patients and families that have reached out to me to tell me, like they showed up in one hospital system, they were critically ill. They were thinking to not be aggressive with them, and then in that situation, essentially they pulled out their MIDEO, and then boom, things start happening, and patients lived. We also have end of life patients that have had their wishes preserved and not over resuscitated and got to die
Mm,
the way they wanted with their plan. And then we have everything in between. We have patients that, take for an example a COPD patient, somebody that has choices regarding ventilation and so on.
mhm, mhm.
We've got stories where patients are able to successfully say when they would want non-invasive ventilation, whether they would want invasive ventilation, meaning going on a ventilator, or whether or not they're just ready to die. And
Yeah.
and again, it's an individualized process, and that stuff has been rewarding to kind of see come to fruition.
Well, and I think it's really important for people that are listening to this to know that it's not a one and done thing. So we did our Mideo card 5 years ago, but now our circumstances has changed enough that it's time for um, particularly Terry to come back and redo it again, you know. So it's not like it's fixed in time and it's going to still apply 20 years later.
Yeah, I mean, traditionally, if you're young and healthy, we build the prescription that you're going to read into video to last you 20 years. But every
Hmm.
5 years, you want to update them just because people usually typically want to update their appearances and so on. Now,
Hmm.
for other people that have medical issues, different. If we risk stratify you differently, that we need to see you sooner because we expect things to change or we know things are going to change, then we're going to see it in a year, or we're going to see in 6 months, or we're going to see in 3 months. I have a patient that I'm going to see next month, that I just saw, and so on. And it's a matter of really kind of curtailing what's needed medically, what's needed in that goals of care conversation, what's needed from a documentation purpose. Because again, the goal here is what's called goal concordant care, meaning that we're doing what you want us to do for you rather than discordant care, meaning we
Yeah.
committed a medical error.
Yeah. Um, Again, things that have changed since we last talked is the medical aid in dying. They call it VAD, voluntary assisted dying here in Australia. In Western Australia, it's legal. Not every state has it legal. But I've worked with a couple of clients here that have, well, one in California too, that have gone through that. And I know that that pulse document was the physician's order for life-sustaining treatment was something that was is also misinterpreted often, and that's something that should always, take precedent over everything. So do you find that the Mideo card is an addendum or replacing a pulse document?
So what we do is a couple of things when we see people. If we see people, patients, and they have a pulse document, we essentially we evaluate it. We evaluate it for concordance, meaning that the patient agreed with what's documented there. And we
Hmm.
often find that it's discordant and that we have to refix it. So we recreate that pulse for them, and we make it right to their wishes. And if it changes again, we change it. Now, what we do at Mideo, though, is we essentially clarify what their intentions are in those medical orders. And we make sure that the Mideo video comes first. And if there's a paper document that exists like a pulse, we make sure that the paper version of the Mideo prescription comes first. And then
Hmm.
they get to look at that medical order. Because again, we know that medical providers, nurses, paramedics, physicians that aren't comfortable and aren't trained in what to do with these things will typically make a mistake. And we
Hmm.
want to make sure that we use MIDEO as the patient safety tool it was intended for, to make sure that we're clarifying your voice, your wishes, and making sure that that's primarily understood by that next medical provider, that next medical stranger in
Yeah,
your care. And that's
medical
always the
stranger.
goal. That's always been the
Um,
goal.
yeah. Well, and that's the Video card is an example of the innovations that are using technology to really advance medicine. Talk a little bit more about what you see in the future with AI and being able to diagnose and genomes and all the. There are so many exciting things that are in the pipeline. And when I'm working with clients that are early um, in their diagnosis, I say, just let's keep it together for 5 years. Who knows what's going to happen in 5 years? And, for some people, I've worked with for that long and they're still alive and, doing quite well. So there is some really exciting hope out there. Yeah.
Oh, yeah, no, definitely. Stuff is always changing, right? Technology is changing, and you've said it yourself. You've had some people and you tell them to hold 5 years and so on. And one of the scariest things I found was in our TRIAD 12 study. And that was a study where we went up to patients that had existing DNR orders and post orders. And even our true end of life patients, those with a terminal illness, those that were ready to die, even when we went to them and said, hey, if something happened during your hospitalization here, would you want us to do advanced cardiac life support to save your life? Would you want us to do antibiotic? Would you want these kind of things? More than 2/3 of the time, they actually said yes, they would. And these are true end of life patients, which is
Hmm.
the scariest thing, because we make these assumptions that we should just follow the documents and orders
Hmm.
without talking to the patient. And patients have goals, right? They have goals. They know they're going to die. They have goals. They might want to see their daughter one more time, or their son one more time, or a grandson, or something. Maybe they have like a pet to take. I can't tell you how many times I have patients that want to basically make sure their cat or their dog is taken care of. So
Hmm.
they're always looking for that little bit of time just to kind of like stabilize things before they do pass on, because they know they're going to die.
Yeah.
So, but you're right. I mean, there's tons of stuff happening in technology, right? AI is a fantastic tool, but it's got to be used with caution. It is
And
a fan
ethics.
and ethics, correct. I
Yeah.
mean, what we're seeing today in end of life care planning and so on is people or companies using the AI technology to really kind of lead people. They're leading them toward a decision, and I find that
Uh,
ethically challenging. Because again, my goal, and just about everything I do in life is middle of the road, to make sure that whatever is being done is really non-biased, and that is going to be right for the person in front of me rather than
right.
for me. I could tell you what's easy for me is to let someone die, or to let someone walk out of an office with a broken piece of paper that's going to harm them. I can do that. I choose not to. I choose to do it this way because it's actually more safe for the patient to be able to do this. And again, when we have systems that are now using AI to talk to people about, what you call voluntary aid in dying in Australia, what we call medical aid in dying in the United States, and so on, or to facilitate their goals of their movement, that becomes ethically challenging to me, because again, it's not regulated. It's not regulated by a non-biased body who can say, yep, this is not influencing to people. And unfortunately, what's being used today is influencing to people.
Yeah, and I think again, it has to do with capacity. And as long as someone has capacity, they can change their mind anytime, And I mean, I can think of people that, got the medication to do the medical aid and died, but didn't use it. They just wanted to have it there. But
Yep, they
that
want
could,
to.
yeah. So, I mean, maybe they were waiting for their pet to graduate from training school. I don't know.
That's very true. I mean, there's so many different reasons people have. And the bean counters just want to have you let them die because it stops the expense. But
Mm.
the humanistic person and you wants to make sure they're getting their last wish fulfilled.
Yeah. Yeah. So you're working with a palliative care now. What's that? I mean, how is that different for you than the emergency room doctor where it was so high intense all the time?
So it's funny in emergency medicine, we do a lot of palliative medicine anyway. I mean, I can't tell you how many patients I've had to have a conversation with a family member and make a really tough decision to either send somebody home in hospice or to, extubate them in the emergency department and let them
Hmm.
die, or to withdraw other types of treatment measures to let them die. So regardless, well, like a facet of emergency medicine really is so, I guess, multidisciplinary that
Hmm.
we end up becoming, very competent in palliative type situations because of the work we do.
Interesting. Interesting. Wow. I mean, I love the whole idea though of once people. I try to encourage people to, when they are ready to stop curative treatments, to get on hospice sooner rather than later, because it's even true here. They're coming into hospice just a few days before they die, but there is a more of a push here to support people to die at home with these age benefit packages that they provide, depending on your level of need, your level of care that you need. And so more people are dying at home, but they need to
That's
be on, but they need to be on hospice and have that palliative approach to be able to do that successfully.
that's actually awesome. I mean, I can't tell you how many times I tried to send a patient home in hospice to die and was told that I couldn't. And it was because they like you have packages there, right? Here in the United
Hmm.
States, home and hospice, it's that 88-year-old spouse that's taking care of you, as you're dying. It's very difficult to take care of a patient who's dying, right? I mean,
Hmm.
you know, they have needs.
I wouldn't recommend anyone to try to die at home without hospice care. Just,
But again, with hospice, even, and maybe different in Australia, but in the United States, hospice doesn't really cover the other types of needs a patient has, like an aide or someone to help, move that spouse. Again,
yeah.
the aging population happening and the silver tsunami that's coming. I mean, we send people, that are hospice appropriate that are 90 and their spouse is 89 or their spouse is older and they can't physically take care of them, and the hospices can't actually provide services there other than the time that they come in for whatever short period of time that is. So a lot of those situations, hospice, for to send a person home with hospice, you need some sort of like medical support, a home health aide, a somebody who can help that family essentially, facilitate, not facilitate, but allow that patient to die with dignity.
Yeah. I worked with hospice when my mother and father were dying, but they died before there was that um, strict 6 month rule. So, like, daddy was on hospice for 2.5 years, and mother was on hospice for 6 years because,
Wow.
they continued to decline. Now, daddy did have to go on and off uh, a few times, but, because he was like already in the system, it was really easy to get him. And they both died at home. And it could not have happened. I was their only caregiver. It could not have happened if I didn't have hospice support. But with that hospice support at that time, there were home health aides that came in to bathe them, and there, all they brought in all the medical equipment, and you know, and it's not that way anymore.
Quite often there's stuff that hospice can do, but bringing in the types of aids that are needed to allow someone to die comfortably and so on typically is not covered. It's usually an out-of-pocket expense, and if they don't have a strong family support system,
Mhm.
they at times won't even take them in. They won't take them
So
in. I'll also tell you,
where are they going to die then?
they usually die in the hospital, and that's
Mm.
part of the issue as far as why too many people do die in a hospital system because they don't have the support system set up at home for hospice to really be effective with those people to send them home, especially from emergency departments around the United States.
And that's so expensive. It's like the most expensive way to die. If you're in
Yep.
a hospital paying those hospital bills, which again, in Australia, you don't have to worry about. But
Which this is also why now families are suing. When patients are being resuscitated, and someone
the
raises the issue that they weren't supposed to be resuscitated, you have a family's estate that's now being attacked, right? You have inheritance that's now being attacked, by the expense of the system and so on. So, it's now to the point that, families get pissed and they call attorneys, and attorneys figure out how to sue, and we have wrongful prolongation of life cases.
Wow. Wow. Okay, so let's go from that to actually what's going on right now with the new reconciliation bill that passed and became law, where it really affects Medicare and Medicaid and trickle down to insurers and talk about patient safety. What are you anticipating? Well, it may not have trickled down yet, but what are you anticipating is going to be ahead in the next couple of weeks, couple of months, couple of years?
So I'm fortunately old enough to know, from different administrations that have been in, whether it's blue, whether it's red, there's always change. And sometimes you have to wait it out. You have to just let the reactivity dwell and stabilize and just figure things out. And that's what's going to happen. That's what's going to happen in the new administration as far as medicine. Medicine's not going away. It's not going, people aren't not going to get medical care. In the United States, we actually have systems that prevent people from not receiving care. There's an EMTALA mandate. So in the United States, you show up in an emergency department, it doesn't matter if you got insurance or no insurance. You have to get what's called a medical screening exam, and that medical screening exam includes a hospitalization if needed. So there's lots of reactivity behind all of this stuff. And again, I try and make sure that you just stay straight in the middle of the road and figure it out, because those people that are way left tend to bring out the reactivity. Those people that are way right tend to bring out the reactivity. And the settling needs to be right in the middle, because that's where most of the work's going to get done, by the middle ground. And the middle ground is going to make it so that people receive medical care and so on.
So on a public policy level, and this is, again, not a medical person at all, but it just doesn't make sense that the US medical system is the most expensive system, but it gets the least bang for its buck for the dollars that it spends. And
Yep.
I mean, the care here is really great, but the offices aren't fancy. And, I mean, you have to be proactive here like you have to be proactive everywhere, but nobody's going to go broke here because of medical debt. It
Yeah,
just
it's
doesn't
crazy.
happen.
The amount of money that's spent on healthcare in the United States, and the life expectancy is declining in the United States because of it, right? It's because it's broken. And look, I've developed many programs over my years in medicine as far as
Mhm.
administration and so on. And when I go into a system and the emergency department was so broken, I'd literally blow it up. I'd blow it up and start over, and just whether it was firing the bad administrators, bad doctors, to bring in the right types. And it's got to be a point where you have to look at it, and you can only patch something so many times. If
Right.
you know I don't want to use a specific type of an example as far as a certain type of doctor, but certain doctors only have a 20-year lifespan in practice. We know it. It's because it's so strenuous. And what you end up doing is patching, 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 until the care is so broken that you have no other choice but to blow it up and just start over. And I think that's what is attempting to be done. I can't say for 100%. I'm sure there's some political right-sided beliefs that
Well,
are
I mean,
happening.
HHS is being dismantled. I mean, it
So,
is. And there may be
yeah,
some good things that come out of it, but
yep,
it is looks to me like it's being dismantled. Yeah.
you're absolutely right. And again, middle of the road, right? So if I look at this and I say, we spend all this money on healthcare, you know, it's broken. We're dying sooner. it makes you think something inherently is wrong with the management and the system itself that really needs to be refixed. And whether or not it's a complete dismantlement, I don't know. I don't see or hear what's particularly happening. I know there's some issues happening with vaccines, and there's always been rhetoric around vaccines. I could tell you I'm a pro-vaccine person. I might not agree with the schedule of the vaccines, but I'm a pro-vaccine person. I may not agree completely of the risk, but I could tell you we could study these things better, right? The whole issue with autism and everything that people are raising in the United States may have some value. There may be some issue there.
Mhm.
But if you completely quell it all the time to say no, 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 and not really investigate it, you bring up fear in people. You bring up fear in people, you bring up
Mhm.
mistrust. I mean, what we did with COVID. I mean, my gosh, when we originally started with COVID, we're vaccinating everybody. And the reality of it was we really needed to be sub-selective in who we were really going after rather than going after young, healthy populations and seeing what we did there. You know, Again, pro-vaccine. I could tell you the vaccine overall worked for a subset of people. If you were elderly, if you had obesity, if you had diabetes, if you had chronic illness, it worked. But
Yeah.
if you didn't have it, it really didn't do anything, and in some instances may have caused some harm. And again,
Well,
that's just
and
that.
the speed that they rolled out that vaccine was amazing, and it did save, millions of lives across the world. And now I think we have herd immunity pretty much,
Yep.
and we may get it, but we don't get as sick. Have you had COVID?
I've never had COVID. Nope.
Oh, I got it while I was in Texas one time. I felt like I'd been hit by a bus for about 3 days, and then I got over it. But I'd had a vaccine, so.
Let me ask,
Well,
did you have influenza? Have you ever had influenza?
when I was in seventh grade, I remember
Okay.
having it, and I was really high fever. Yeah.
Yeah. So I had influenza when I was a medical resident, on a surgical rotation, and I got walloped. I felt like I got hit by a bus. I felt like I was dying. I mean, for 5 days, I was just down. So and a lot of people that I've talked to that had COVID, if they had influenza, a really bad case of influenza, they said it was
Hmm.
about the same. But again,
Hmm.
that's select groups that you talk to.
Interesting.
Other people said they had a sniffle. Other people felt like they were dying. And I could tell you I've taken care of many patients with COVID that were dying and so on. And every case was a little bit different. And
Mm.
it's the whole issue of just needing to study it more. And rather than really saying, hey, we did this wrong, we did that wrong, we really just need to be matter of fact about it all and
Are
study
you
it and be truthful about it.
are you worried, or do you see brain drain? People that are leaving the medical system and going to either the private sector or even other countries?
I think people are frustrated in medicine, and again, it's a broken system, right? And I think doctors are taking it on the chin right now to levels
Mhm.
that I've never seen before. The level of mistrust to doctors trying to recommend a treatment is unbelievable. I mean, look, for me to tell a patient who had a heart attack they need a statin and them tell me, no, I don't want to do that. There's too many side effects. I'm like, look, I'm on a statin. Like, I'm on a statin because I know they work. Trust me, I'm not going to recommend something to you, but the perception is that doctors are just recommending things because they're getting money from drug companies and pushed by drug,
Yeah,
and it's not the case. Not the
yeah.
case at all.
So much misinformation. So, what's your vision now for MIDEO going forward, and where do you see it in the next 5 years?
I think now with insurances paying for advanced care planning, I think the other portion that needs to happen is companies need to offer it as an employee benefit. A number of
Yeah.
companies do this already. They do, 5 wishes, or they do some other document, LegalZoom, Rocket Lawyer, whatever. I think now advanced care planning needs to be an employee benefit. We've had situations where we've had MIDEO as an employee benefit. We just did our own company as far as USACS and just did 1,000 employees, and they, by and large, I don't know that anyone had a negative feeling about it. Everybody felt, hey,
Mhm.
this is a very valid thing to do, and it was appropriate. The other thing I think needs to happen is that The Uniform Healthcare Decision Act about a year ago or so announced or approved the use of digital tools, video, to essentially document your advance directive wishes. I think
Now, are you
every
talking
state,
about telemedicine appointments or
nope, nope,
no?
nope, just as far as your advanced care planning stuff and
Oh,
tools,
okay.
the patient. And I think somehow that needs to be federalized. It needs to be federalized that, if they make a decision, it should go across all 50 states. It shouldn't be left to the individual states, to him and ha, and say, no, we don't want to
Hmm.
do this, for whatever reason they're trying to protect it. Any person who documents their wish in any way, shape, or form, whether it's video, on paper, as long as it's done appropriately and with moral standards and so on, should be considered valid. For a state to look at something and say it's not valid because it doesn't meet their I cross my I and dotted my T, so to speak, then that's broken. It's a broken system, and there really should be one process for this across the nation. It shouldn't be individualized according to states. We have states that have different definitions of the word DNR. We have states that have different applicabilities to the word DNR. Like it's broken.
Well, okay, so it's broken, and I think that's why I really like to encourage patients as much as possible to take responsibility for themselves, to look ahead and plan ahead for anything that has to do with the quality of end of life care that they want to have. And why, again, I really recommend the MIDEO card is because it's an informed decision. It's you as the patient are taking responsibility to get informed first before you make these really life or death decisions about your own life. And
Yeah.
I think that's the operative word is it's an informed decision.
Yep. And to leave people with just a thought process, right? So if you can't speak for yourself, who's gonna? Truly, if you can't advocate for yourself, who's going to do it? You have to figure that out, because with MIDEO, we give you that ability. We give you that ability to do it yourself, or we give you that ability to do it through your agent. If you don't, you're simply putting yourself in a situation where you're saying, I'm going to let somebody else make the decision for me. And you have to be okay with that outcome at that point in time. I could tell you, with the way things are happening across the country and internationally, I don't put that much trust in the medical systems to get it right for me. I'm going to be the one that says, I'm telling you what to do for me. And I think MIDEO gives you that ability.
Well, so as you're, I mean, we're both aging, but I'm aging more than you. I mean, so how are you looking at your plans and your preparation and what you want to have in place for your family if you died unexpectedly?
Yep. So, and again, I'm a little fortunate, right? Because this is the space I'm in and so on. So I make sure things are documented. I make sure my estate is set up correctly so that my kids and my wife will be able to essentially continue on without me. You know, I do have my wife as my decision maker, if I'm not able to speak for myself, but primarily, the goal is essentially to make sure people can speak for themselves,
Mhm.
and if you can't speak for yourself, then again, who's gonna? And we want to make sure that we appoint that person. So that's what I've done. I've made it so that, my estate is set up that way. I made it so that my kids essentially will have a stepwise process into things that they get and don't get. And maybe that's the right thing to do, maybe that's the wrong thing to do, but that's what Fred's doing.
I mean, I'm just curious. You don't have to get into the nuts and bolts of it, but I mean, they talk about physician heal thyself, so it's
Oh no, I'm not
yeah,
that dumb. I see doctors. I go to a cardiologist. I make sure I got a great internal medicine doctor, as far as my general practitioner.
yeah,
So, like, doctors heal themselves. Most doctors are smarter than that and actually go see doctors,
yeah, yeah.
And again, we don't listen to the rhetoric, like all this stuff about, a Pneumovax vaccine. You know what? I took my Pneumovax vaccine, statins.
What is the Pneumovax vaccine? I don't know about that.
It's the pneumonia shot that we recommend to people when they get a certain age, right?
Yeah,
Flu
yeah.
shots and so on. And again, all the rhetoric behind all of that is just insane, and there are great medicines out there that we use, right? Some have complications, there's no doubt, but generally speaking, we got to the life expectancy we are at because we embraced medicine and we embraced pharmaceuticals and just use them appropriately. We got to a peak, we're starting to drop. Now we need to relook at it. We need to relook at it and see what we were doing that was really working versus what is not working. And again, I think the level of mistrust out there is going to make it harder to take care of people in the upcoming years.
Yeah. So again, you just need to be your own best advocate and be as informed as possible, because there's just a lot of different cracks you could slide through if you don't. I really appreciate you giving me your time again and seeing you again, and being updated with, and just knowing now that we need to update our stuff too. So we'll be in touch with you, but let's talk about how, if people want to get hold of you and to make an appointment to, maybe not you specifically, but to get a MIDEO card. First of all, I would recommend anyone that wants to hear the real details that we got into, go back to the 2020 podcast that I did with Dr. Mirarchi on just YouTube, Dr. Fred Mirarchi. I'll put the link in the show notes. And we really got down into the nuts and bolts about what the MIDEO card is, but I'll also have it in the show notes how to find your website. And, I think it's just really important. And if it's paid for by insurance, I just think everybody should have one. Pardon me?
No brainer. I said it's a no brainer. If your insurance is going to cover it, the medical expense behind it all, it's a no brainer. Not to mention
it's a no brainer.
To do it, what's it going to cost you? It's going to cost you between $700 and $1,000 to get a living will and a healthcare power of attorney document, and that's just insane. It really should be something, if we want you to have, that we figure out how to get it to you economically, and that's also what we've done in the medical system here.
Yeah. Well, thank you so much, and I just loved learning more from someone with your experience and background, but that you're just so nice too. I really like that about you. So,
Thank you.
Anything else you want to say before we sign off?
Yeah, I hope people realize there's a call to action here. The call to action is your safety, and there's no other way to say it. If you think you're going to go through a very complex healthcare system with a piece of paper and have your wishes followed, I want you to think again. Because your thinking's broken, and we need to make sure that we actually protect you. It's a very broken system, and MIDEO is the only product today that exists on the market. Not that we're not encouraging others to come in, but it's the only one that exists on the market now that you can actually have a say with your voice, have your visual appearance reflect how you feel about what you're telling that person, and really inform that person on how you want to be treated.
Thank you. Hear, hear.
You're welcome.
All right. We'll talk soon, okay?
Sounds great.
Okay. Bye.
Bye-bye.
Thank you for joining us on Dying Your Way. If it's inspired you, then please spread the word. Leave a rating and review so others can find out about us. To learn more, connect with us on Facebook or our website at dyingyourway.com. A special thank you for the artist Mel Dobra for letting us use her song, Smoke and Flame, as the soundtrack of our show. I invite you to return, hear each episode, and be part of the conversation on death literacy. I am Claire O'Berry, and this is Dying Your Way.